This lecture is going to be a summary of the different types of factors that we're going to be using in trying to compute monitor units. I want you to take note of the address, the web address up here, in case you need to refer back to that. It's not so much an advertisement for this place as it is just that they're the ones that put the summary together. And I want you to be able to understand where these monitor unit calculations come from and what factors are used in order to generate a monitor unit calculation. So for photon field MU calculations, here is your overall equation. You can see all of the factors that are enumerated here, and you can see how this works. You've got the prescription dose at whatever your depth of interest happens to be. In other words, you want to deliver, say, 200 centigrade to a certain spot in the body. That's what you're going to be putting up here. This dosage amount, if all of these factors under here were 1, would equate to the number of monitor units that you need. Now, we all know that's not going to happen because there are several other factors here that you have to be concerned about as you go through. But if all of these factors were in fact 1, then the Rx would equal the number of MUs, but obviously that's not the case. So the question is, how do these factors change? What is it that causes these factors to change? Well, number one, let's read these from left to right. O here is going to stand for the output factor in units of centigrade per monitor unit. In other words, how much centigrade is delivered per monitor unit? And that's what the O is going to be here. Then you've got a factor here, which is either going to be PDD or TMR. Now we'll get to this in just a minute. TMR stands for tissue maximum ratio, and it's the simplest method for computing required in an isocentric technique. And that's most of what you guys are going to end up having to deliver. In other words, we're going to put the isocenter at a certain spot in the body. We're not going to do an SSD setup in many cases, not all, but in many cases. For those cases in which you have an SSD setup, we would end up using a percent depth dose. And if you have a non-isocentric technique, that's what you're going to end up using. So in other words, we're not setting the isocenter somewhere in the body. We're setting a certain distance to the skin, something like that. This is the factor that we're going to end up using. So that's why I want you to know the difference between these two. Now, the next factor here, S sub C, this is going to be the collimator scatter factor. And we'll get to that in just a minute. This right here, SP, is going to be the phantom scatter factor. Now, these factors here, or this factor here, can definitely be significantly less than 1. And what happens when a factor is less than 1, that means that the number of monitor units is going to increase. When a factor is greater than 1, that means the number of monitor units is going to decrease. So bear that in mind as you're going through here. Okay, so we've covered the collimator and the scatter and the phantom scatter. Then you've got the ISC, which is the inverse square correction, or the inverse square law. That is going to follow from these formulas, depending on whether or not you're using a PDD or a TMR. Next is TT, which is a treat to level, taken to be 1 if isodose line is not specified. A physician might prescribe to the 90% isodose line. So a lot of times here, this, I don't know why they call it TT, but it is an isodose line prescription. In many cases, if a physician is going to prescribe to the 100% isodose line, which generally is going to happen with isocentric techniques, then that treat to factor, the TT factor there, is going to be just 1. If for whatever reason you need to treat to another isodose line, then that could be, maybe you want to go to the 95% line, maybe you want to go to the 105% line. Kind of depends on different cases. Most of what you will end up dealing with is just going to be treating to the 100% isodose line, which means that TT factor is just going to be 1. Next is going to be WF. It's going to stand for the wedge factor. And if you don't have a wedge, basically we use 1. Again, when we use 1, that means that the number of monitor units is neither going to be increased or decreased for this particular factor. TF, in this case, is the transmission factor, taken to be 1 if no trays or other devices are placed in the beam's path. So if you don't have a tray with a block in it, then you don't have to worry about putting in the tray factor, which is going to decrease the amount of radiation that's actually making it to the target. And then you've got the OAF, which is the off-axis factor. If the calculation is done along the central axis, then obviously you're on axis and not off axis. And if you're not off axis, then this factor is going to end up being 1. So I know there's a lot of factors here. I mean, what are we looking at? 1, 2, 3, 4, 5, 6, 7, 8, 9. We got 9 different factors here, but they all try to account for what's going on that might change the output of this particular setup. And so that's the adjustment that we want to make. So you can see here, and we'll go through again these scatter factors. The collimator scatter factor is going to account only for scatter arising from the treatment head. It's the ratio of the output in air for a given field to that of a reference field. For its measurement, you can see that no phantom is used, best used with the ion chamber with the buildup cap, and most commonly measured at isocenter. I'm not so concerned with finding out that you know how to do all of this stuff, because you're never going to be calibrating a machine, but this is the basis upon which we try to generate the factor. The phantom scatter factor accounts only for scatter arising from the phantom. That's the difference. This is from the treatment head, the scatter off of it. This is from the phantom. It is the ratio of dose rate for a given field size at a reference depth to the dose rate at the same depth using a reference field size with the same collimator opening. So it may be determined for all field sizes by taking a total scatter factor and dividing it by the collimator scatter. The total scatter factor arises from scatter that includes both treatment head as well as phantom scatter, and it is defined as the ratio of the dose rate at a reference depth for a given field size to a reference field size. This, you can think of this as a combination of this and that. Okay, so now let's go on and let's look at some of these other factors here. PDD, of course, is going to be the ratio of dose at a given depth to the maximum. So you got a given depth here, and then you got a maximum. PDD is a function of depth, source to surface distance, and the field size. So all of these components here are put into the PDD function, and it tells you what the dose at depth D is compared to the dose at D max. The Maynard F factor is the ratio of the inverse square component of percent depth dose from the reference source to surface distance to another one. Now, we've been through the Maynard factor here before. So we've seen the inverse square correction before, and the inverse square correction for the second SSD is compared to the first. How does that change? This is accurate for small shifts, but it only accounts for the effect of the inverse square law on PDD. Full correction would require addressing changes to phantom scatter as well as attenuation in air. Okay, So now we're going to go from PDD and we're going to go into the tissue error ratio. Now, some of this actually got covered in one of the other chapters, but it's always good to review. The tissue to error ratio is the dose at which the point in the phantom D, sub D, to dose at the same point in free space with some sort of buildup. So you got your phantom here, you've got your point. They're both at along the same line. So you're seeing the same collimator distance here for both of these. What you're wanting to do is you're wanting to take the tissue part of this, which is some point well within a phantom, and divide it by that some point in free space. The tissue to phantom ratio is the ratio of dose at a given point and depth in the phantom to dose at the same point at a reference depth. So you've got some sort of reference depth here that you're going to be comparing this measurement to. This measurement goes on top and this measurement goes on the bottom. You'll notice that same theme as you go to this will be on top, this will be on bottom, this would be on top, this would be on bottom. The tissue to maximum ratio, tissue to maximum, let's try that again. Tissue maximum ratio, TMR, is going to be the ratio of dose at a given point and depth in a phantom to dose at the same point at depth of maximum dose in the phantom. What's different about this as opposed to this is that our reference point here is going to be at D max. Here you can set it anywhere you want within the phantom. Here, this is set at D max, and that's why you change the name to maximum. A backscatter factor is the ratio of dose at depth of maximum dose in the phantom to the dose at the same point in free space. In other words, this right here adjusts that distance to D max. So you probably move this line up a little bit to put it at D max. Again, your collimator size is going to end up being the same, but at D max, that's where you get the measurement there in order to generate the backscatter factor. That's the only difference between the backscatter factor and the tissue to error ratio. Okay, so here you have the equations that allow you to convert from TMR to PDD, PDD to TMR, and you have TMRs to TARs and TPRs to TMRs. There's a lot of derivation that goes along with that. I don't really expect you to be able to do that, but these are the types of equations that will allow you to be able to go from one to the other. And you can kind of see they're trying to make a summary over here as to how to be able to do that. So that's a lot of what I see out of this that is of value to you. One other thing here that we can go over, since what we were discussing here was the monitor unit calculation, this was for photon fields. This equation is for electron fields. You'll notice a lot of the same stuff. I wish I could put these side by side, but you'll notice quite a few factors here are missing. Like you don't have a wedge factor, you don't have an off-axis factor, and that kind of thing. You do have the output factor. You've got the PDD because electrons are usually set at a distance away from the surface of the patient. The AF is going to be the application factor. So that's the ratio of the output with the utilized applicator to the output with the reference applicator size. A lot of times the physicists are the ones that'll go through and try to figure out what this applicator, well, actually it's the cutout factor. That's what I'm trying to think of. Anyway, this is if you're using a specific applicator with this as opposed to some sort of reference that they might use in order to calibrate the machine. Cutout factor, and the cutout that they're talking about is, you know, having the block there. what is the output with the cutout in it as opposed to the output without it. The treat 2 level of the TT, again, is going to be the isodose line. In many cases for electrons, you're going to be looking at somewhere between 80 to 95 or something like that. So you're going to be looking at factors here that are 0.8 to 0.95, something along those lines. And you've also got an inverse square correction here, depending on the virtual source distance, since you don't really have a point source per se, you have a virtual source here. And then you've got the G, which is going to be the difference between the reference acidity and the setup. So these are the types of factors that you'll need here for the electrons. Electrons are a little easier. If you can do the photon stuff, without even really thinking about it so much, then the electrons shouldn't be that much of a difficulty. You even have a knowledge test down here, which you can kind of go through and work through if you would like to. So anyway, I thought that might be of interest to you, so that's why I did a video on it, and I hope it helped.